Okay, dokes. Right. Well, I am pretty much blown away with the number of people that have logged in. So there's a huge amount of pressure to actually produce something decent. The only saving grace is that nobody's had a drive to go anywhere and you're sitting in your gardens or you've got a glass of wine, hopefully. So that'll make it a wee bit easier. I'm Mark Frame. I'm one of the consultants that work up at Southampton General and in the Spire in Southampton and in the Wessex Nuffield. Got a practice now that incorporates paediatric soft tissue knee in Southampton General and in the Spire. So I thought it'd be quite a good thing to do, just to kind of go through. A lot of this stuff overlaps with adult, but there's some unique things and things that are much more prevalent in kids. So we'll start and go through some of those. So moving on from ACLs, and actually the meniscal stuff, obviously we're separating it out to make it easier to go through things, but very, very, very frequently, an ACL and a meniscal tear go hand in hand with each other, and a medial meniscal tear is very, very common given the kind of pivoting type injury that you need to do to damage your ACL. So again, focusing on Sophie, who's 14, fit and healthy, playing netball, landed, twisting her knee, felt immediate pain, but what's different from the history with this one in comparison to the first one is that she was a bit limpy, but managed to keep playing on and was not too bad. Woke up the next day, but her knee was pretty swollen. It wasn't immediately after the day. Took it easy for a couple of weeks. Didn't feel the need to go up to minor injuries, didn't end up with any x-rays. Was back playing netball without any real issues, been after the school holidays and it was fine. Just doing something simple after the match, crouched down for her shoes and suddenly had pain and kind of a click in her knee, and could bend it but just couldn't get it out fully straight. Went to minor injuries and, while she was there, it kind of loosened off and her knee suddenly went back to normal. X-rays were normal, told it was just a sprain, ended up getting referred to ortho, but it was vetted because the knee was bending, it was moving, it was kind of a vague story, ended up with a 3-month appointment, but she was intermittently locking and went to the GP. Now this is the one that's super important because, the longer somebody at this sort of age with a major meniscal injury is around and it constantly keeps locking, that meniscus keeps moving, the more harm she's doing to that and the less likely it is that we're going to be able to do something with it. The examination is important, but again, I wouldn't really get caught up on it, particularly with meniscal tests. I think I do a McMurray's almost out of orthopaedic ritual rather than because it's actually telling me anything. In my head, I've already decided that they've probably got a meniscal tear and I'm going to do an MRI scan. And you kind of poke it, and when they go, it's sore, you're like, oh, that's because they've got a meniscal tear. And when they don't say it's sore, you kind of ignore it. So it's not a sensitive test, it's not specific, it's pretty rubbish. So I wouldn't get too caught up on meniscal tests. Obviously if somebody's got a frankly locked knee, then that's an emergency. You don't leave that. They don't walk around with crutches for another 3 weeks, which we've seen, or even longer. It was the longest I think I've ever had is somebody that's been like 2 months with a knee that hasn't bent and they haven't been able to go to work or drive and hasn't been referred up other than on a routine referral, which is insane. So again, acute knee clinic, an MRI scan if you can possibly do it, an x-ray again, because there's lots of different things that can potentially lock your knee that aren't a meniscus. Again, even if it's unlocked and their knee is bending and they're talking about locking, an x-ray is useful. If they've got a great big loose body, they've got a big osteochondral fragment that's been floating around in their knee, then you'll see that on the x-ray and just gives you a bit of extra a bit of an extra lead as to what's going on. So it's unbelievably important, your meniscus. Best picture I've seen is this one up in the top corner that I kind of draw on a piece of paper when I'm trying to explain to patients why their meniscus is important and why taking it away is such a big problem. So you can see the femoral condyle is really round, your tibia is really flat, and your meniscus really acts as an interface between that and allows the force to get spread more evenly over the tibial surface. If you took away the meniscus and you have a meniscectomy, it's a bit like putting a ball on a table. There's a very small area of that ball that's actually in contact with the table. And there's a huge amount of force that's been focused over that. You talk about somebody single leg standing or jumping on something, you've probably got 70, 150 kilograms worth of force going through that tiny surface area over the cartilage. It's no wonder that you end up with osteoarthritis or damage to the articular surface. A good analogy somebody explained to me was, you know, it's like, which would you rather have? Somebody stand on your hand with a stiletto, or somebody stand on your hand with a welly, but the same weight. Obviously, the force focused over a smaller area is going to hurt more, and that's what happens when you take away somebody's meniscus. In children, you've got a small group that have a congenital abnormality of their lateral meniscus normally, where they have a discoid meniscus, and that's just, instead of it being C-shaped, it's like a carpet that covers the entire surface of the tibial articular surface. And you can imagine if you've got something that's actually in between those two moving surfaces, then it's far more likely that it's going to tear. It's almost inevitable that you're going to end up with trauma to that. Like I said, so you have a much higher chance of osteoarthritis or post-traumatic OA in early years. An early MRI is absolutely important, because under almost all circumstances, if you can try and save the meniscus, then that's by far the best thing to do, you know. And the sooner you get into that knee, the more likely you are to be able to actually salvage it and repair it and fix it. If you look at the picture in the bottom corner, that's a meniscus in cross section, and the blood supply to a meniscus is really poor, and it regresses as we get older. So, you know, pretty much after the age of about 15, that meniscus is getting less and less likely to heal, and the blood supply is poorer and poorer. And unfortunately, the red zone is the zone that we want to fix. But if you've got a tear in the red zone and it doesn't work, or you don't get it fixed, that's really setting you down a road of taking almost your entire meniscus out of your knee, which is absolutely catastrophic. It's an arthroscopic procedure. It's really quite straightforward and quick to do, but it's quite technically difficult. And I think, again, it's a bit like some of these other things. If you send it to somebody who's not that interested in it, or it's not their main focus, they might have a try and see if they can fix it. But if it's a bit too difficult, then it will just get chopped out. And so, because of the importance of it, you really want somebody who's going to do absolutely everything to try and salvage it and fix it. So that's an MRI image. The one on the right-hand side shows what's called a double PCL sign. So you can see the black line for the PCL, and you can see another black line in front of it, and that's their meniscus sitting in the notch in front of PCL rather than at the back of the knee where it should be. So this is a little video that we did just the other day, actually, of somebody's meniscus, and you can see how unstable that meniscus is, and it's almost their entire meniscus that's been torn around the edge. Use a shaver just to kind of roughen it up so you've got a bleeding surface for it to actually heal itself back together. And these are the meniscal sutures that we use, all inside the knee. So this is all inside through the tiny little portal that we make for the scope. And you can see this coming back, and you'll see a loop of suture, and it works like a little seatbelt, and that just snugs the meniscus back into the side. And this is just one that we've put in, and actually, you know, normally with these you may put 3 or 4 in that you need to actually secure the meniscus back down. So we'll see in a minute, when you pull on the string, it acts like a little slip knot, and you can see that it tensions the meniscus back to the rim. Afterwards, that's why the rehab's really important, because those are really tiny sutures, and you put 3 or 4 of them in, you've got a really unstable meniscus, you've got a really unfavorable environment for this to heal, you've got a poor blood supply, and you've got somebody who's raring to go. You know, it's a recipe for disaster. In the more movement you have there, the less likely it is to actually heal back together. So this is one of the few circumstances that I'll end up putting a brace on somebody, and we lock it at 90 degrees, just so that they don't bend too far. And that deep flexion, your femur acts like a cam. So rather than just pivoting on a central kind of point of rotation, your femur rolls off the back of your tibia, as you know. And as it gets to that point beyond 90 degrees, it starts to push the meniscus forward, and it will stress the fixation that we've done. And we know that about 19% of these fail. And if you have none that fail, then you're not doing enough of them, because you're chopping things out. So patients need to be aware that this isn't an absolute fix to their knee. They have to be aware that there's a possibility that this will fail. But you know, I think even the risk of a second surgery is far outweighs any kind of you know, you need to try and fix it. You know, you can't do anything else. But obviously, if patients really don't want that, then that's up to them. But you know, I've never seen anybody that says they don't want their meniscus fixed if they can have it fixed.